Okay, magandang hapon po muli. Dito po ang Coalition for People's Right to Health at welcome po ulit sa isa na naman pong talakayan na online, ang ating webinar po. Tungkol naman ngayon sa kung totoo nga ba no, na tayo ay nag-flatten na ng curve. No, marami na tayong naririnig. Dati pa po natin hinihintay at inaabangan ang sinasabi nga pong pag-flatten o pagpatag ng kurba ng mga kaso ng COVID-19. No, kung papansinin natin, itong sa huling mga araw, ay parang bumababa kuno no yung mga kaso ng COVID-19 na nakikita natin. Nasanay po siguro kasi tayo na umaabot tayo ng 4,000 kaso sa isang araw. Na ito yung mga nakita natin noong Agosto. Kung titingnan natin yung mga bilang ng COVID-19 na kaso sa August ay mas mataas. No? In August 2020, mas mataas ang kanyang mga kaso kumpara sa pinagsama ng mga kaso mula Marso hanggang Hulyo. No? Yung talagang gano'n karami yung naging kaso natin ng COVID-19 in August. No? Kaya talagang tinitingnan natin, totoo nga po ba yung mga sinasabi ng ibang mga analyst at ibang mga nagsasaliksik sa mga datos na posible daw na nagfa-flatten o kaya umabot na tayo dun sa pinaka-peak, no? Pinaka-rurok ng ating mga kaso ng COVID-19. Pero syempre, marami pa po ang sinasabi sa datos na kailangan pa nating alamin. At ito nga po ba, nakikita natin sa datos, talaga po bang nagre-reflect o nakikita po ba talaga natin siya sa ating tunay na buhay, no? Lalo na po sa mga ospital, kung asan talaga dapat yung mga may malalalang sakit ng COVID-19, pati po sa level ng komunidad. No? Kaya nandun tayo din sa kung saan unang nakikita, lalo na po yung mga mild to moderate cases at kung saan nanggagaling ang mga close contacts ng ating mga positibong kaso. So, kailangan natin muna makita ano ba ang tunay na sinasabi ng datos, ano po ba ang kalagayan sa ating mga ospital, at ano po ba yung itsura ng sa ating mga komunidad, at lalo na kung yung kahandaan ng ating gobyerno na talagang masigurado na nagpa-flatten ang curve at masabi talaga nating manatili tayo sa ganito dahil alam natin bagamat posibleng ma-flatten yung kauna-unahang kurba, eh pwede pa rin magkaroon ng tinatawag na second, third, fourth wave na nakikita natin sa ibang bansa na posibleng maging malaking pahamak din sa sistemang pangkalusugan at yung mga napakita sa kasaysayan na ang mga second wave ng mga infeksyon ay pwede rin maging singlala kung hindi mas malala pa doon sa unang pagtaas ng mga kaso ng isang nakakahawang sakit tulad ng COVID-19. No, kaya samahan niyo po kami ngayon sa Coalition for People's Right to Health na alamin natin, no, are we really flattening the curve? No? So tingnan natin sa ating mga speakers ngayon. Meron po tayong tatlong makakapanayam. Ang una po ay isa pong nagsasaliksik sa datos, no? So siya pong data analyst at national chairperson ng AGHAM, no? Kaya yung pangalawa naman po nating speaker ay isa pong intensivist at pulmonologist sa dalawang malaking ospital at tanyag na ospital sa St. Luke's Medical Center at Philippine General Hospital. At ang pangatlong speaker naman natin ay isa pong provincial health officer sa isang probinsya na medyo may kalayuan talaga sa Metro Manila. So ano po ba talaga ang kalagayan hindi lang po dito kung saan ang kasagsagan ng COVID-19, pero pati dun sa kanayunan kung saan nakikita natin o posibleng hindi pa nababalitaan na tumataas din ang kaso ng COVID-19 at bumapadya pa lalong tumaas, lalo na po sa mga lugar na hindi masyadong nababalita. No? Kaya samahan niyo po kami ngayon sa ating mga susunod na minuto at oras para malaman natin, no, are we really flattening the curve? At isa po ito sa mga webinar na gagawin po ng Coalition for People's Right to Health para malaman ng taong bayan ano nga po ba talaga ang tunay na kalagayan ng ating sistemang pangkalusugan kaharap ng COVID-19. No? Sige po, so hindi ko na po muna patatagalin. Diretso na po tayo dun sa una nating makakapanayam sa araw po na ito. Ang una po nating speaker ay si Professor Giovanni Tapang. Siya po ay Dean ng UP Diliman College of Science. Siya din po ay nakapagtapos, no, ng kanyang Bachelor's of Science, Master of Science at Doctor of Philosophy in Physics sa UP Diliman. Siya po ay kasama din po sa UP Pandemic Response Team at kasalukuyan pong National President ng AGHAM. So, magandang hapon po, Professor Gan.
Good afternoon, magandang hapon sa ating mga nakikinig at sa ating mga interesado dito sa tanong. Actually, marami dito sa mga numbers ko ay galing sa website ng UP Pandemic Response Team, ang endcov.ph. Ito ay ginawa na ipunin ng UP Resilience Institute at ng UP system, kasama yung ilang mga ating mga profesor mula Los Baños, Manila, Diliman, at iba't ibang mga eksperto. Kaya ako gustong nakita ba yung screen? Kaya ako gustong i-post yung question na nasaan na tayo ay kasi parang una, may mga numbers kasi na mga nadidiscuss at marami na pwedeng maging interpretations dito. Kaya pag pinag-usapan kasi yung flattening the curve, for example, this was a plot that was being shown around during March early this year. At dito pumapasok yung usapin ng flattening the curve. Ito yung pinapaliwanag noon na kung walang precautions, mataas yung magiging peak natin, mabilis at magiging early. At lalampas siya doon sa health capacity ng ating healthcare to sustain or to address yung mga cases na papasok. So for us to be able to be ready for that, we should make ways to flatten the curve. In other words, delay the onset of cases, limit the interaction, meaning impose social distancing, and also to tell people to wash their hands, to use their masks, etc., so that we can actually flatten the curve or lower down the cases, delay it further so that there will be time for the healthcare capacity to be built or to catch up. Yun talaga yung konteksto ng flattening the curve. Hindi ibig sabihin niya na tapos na ang pandemya, zero na ang cases bukas. Pero dalawa yung requirement niya. Una, yung pagbaba ng mga cases at pag-slow down ng mga cases. Number two, naabot na natin yung healthcare capacity. Maybe the biggest misnomer came from the point na ang interpretation ng flattening the curve ng maraming mga tao ay yung peak, tapos na yung peak. That's another question altogether. Umabot na ba tayo sa peak ng first wave? Then let's look at the data kung talagang ano yung pwede nating makita na tinuturo sa atin nung data na ito. So let me go back also to an earlier paper or a plot that was used in the one of the first few reports done by the UP Pandemic team, talking about what will be the effect of the enhanced community quarantine and the conditions or the context at which why we are actually looking at the possible effects after the lifting of the ECQ. So ang idea again dito, meron kang may capacity lang na kayang gawin ang kayang i-sustain ang ating mga hospital, ang ating mga health workers, and therefore we don't want to overtax that health system capacity so that kung may cases man na dumarating ay makakayanan. So ito yung konteksto na to. After April 14 ay magkakaroon ng modified community quarantine, limited pa rin yung movement. Tataas yan pero bababa afterwards kasi as the epidemic would actually burn itself out. Of course, the problem at this time was that hindi naman din gano'n naging consistent yung pagtataas or pagsusustain ng health system capacity at pag-increase ng health system capacity, hindi lang dito sa Metro Manila, kundi sa ibang mga bayan. And at the same time, after the lifting on April 14, there was also this program of Balik Provincia that actually brought locally stranded individuals back to their provinces, which actually triggered cases on those areas that were none before. Ito yung konteksto ng mga data na tinitingnan na lumabas ngayon at sa ngayon from the work of Dr. Cayton and the UP pandemic team, ito na yung itsura ng ating reproductive rate, instantaneous reproductive rate ng virus, kung saan ay may mga lugar ka na mas mababa than 1. Yung R of T, which is the reproductive rate of the virus, meaning an individual will not be able to infect another person, meaning mas mababa sa isa yung kanyang, if you take into account everybody, so mas konti yun na infect niya at this point. This was the map was based on the September 7 data. Now, right now, the R's of T, we always are welcome the number when it's below 1. That means that it's the virus is not it's not being transmitted as efficiently as before. Now, kung titingnan nyo, mababa na naman pala. R of T is less than 1. So, okay na. In fact, I'd like to go back. The reason why I got this screenshot from the dashboard of the pandemic team was that were there times before that R's of T is actually lower than 1. In fact, kung titingnan nyo, the blue dashed line is the one that is 1. There are several times that we were below 1. And in fact, the lowest that we have been was in April 10, 2020. And it has reached 0.64. This was during the ECQ. And even then, tumaas pa rin. At umabot pa rin sa point na minsan lumampas na siya ng 2. Okay? Kung titingnan natin, hindi din basta-basta ibig sabihin na R's of T is less than 1 ay okay na. Pwede nang mag-relax ang mga tao, wala nang problema, tapos na ang pandemya. As these numbers have shown us, in April 10, we've reached 0.64, and yet we are still here in the time that we've reached near 200,000 yung cases natin. So it really tells us that just looking at one number like R's of T does not really give us comfort. We really have to look at it as a whole. Na ito ba ay nag-decline or less than 1 for 14 days, as the WHO has said. Umabot na ba tayo ng number na yon? At kung ganon, yung cases mo ba ay talagang na-manage mo na kung ano pa yung mga kung may nakuha pang mga bagong cases. And for you to be able to do that, are you doing enough testing? Now, there's one other issue that is the same thing actually can be seen with doubling time. Even if you look at it as doubling time, there were times that the doubling time is much larger than 1 month. And again, maganda nga sana kung patuloy ito. Pero caution lang din sa atin na hindi rin naman necessarily na pag mataas na to ay assured na tayo na tuloy-tuloy na to. Kailangan tuloy-tuloy pa rin na buo na hinaharap yung problema ng pandemya. Now, This is a simulation by Dr. Bahante of UPLB, projecting the active cases in the Philippines up until December. And you will see that the active cases will plateau to around 80,000. That means you have 80,000 possible cases, individuals who could infect other people. If you don't manage them well or isolate them well, pwede rin talagang magkaroon na increase ng cases. Now, there's one other thing that I'd like to point out. We still have around 40,000 cases that are not reflected in these graphs. Yung mga kailangan pong validation. 40,000 is a large fraction of say active cases of 80,000. So we don't know how many of these 40,000 really are still active. And until the DOH solves that backlog of 40,000 cases, it's very difficult really to ground our predictions on reliable data. Kailangan talagang mailinaw kung kailan ang onset ng cases ng symptoms, kailan sila gumaling, saan sila galing, para mas mabuo yung picture ng pagkalat nitong disease na to. Because it's really difficult to do this just looking at the numbers for the Philippines, because it might be that for the Philippines the number is like this, but there are areas where it can propagate itself, and from there, yun naman din yung magiging bagong epicenter ng ating pandemya. So those things that should be taken into account. Just to summarize, we do have numbers that are less than 1 as of September 7 of the reproductive rate. But just to remind us that if we just do nothing again, then this can also go back and rise again, just like what happened in April. Kailangan pa rin ng maayos na contact tracing, kailangan maayos na testing, kailangan pa rin maayos, hindi lang yung data na to, kundi yung data ng maihanda pa rin yung mga hospital at yung mga clinics na magtatanggap ng mga cases, maybe not in Metro Manila, but also, not just in Metro Manila, but also in the areas where ngayon pa lang tumataas yung mga kaso. So yun lang. If there will be questions, I'll be happy to answer. And I might slug out a bit, but Josh can text me and I can answer even during the while your program is still happening. So yun lang po. Thank you very much and good afternoon.
Okay, maraming salamat po, Professor Giovanni Tapang. Prof, i-clarify lang namin, no, yung what we've been hearing a lot ngayon, no? Siyempre may mga nagsasabi na the Philippines has flattened the curve, and something that is echoed actually even by the President himself, no, dun sa previous address niya. Would you say po, or is there any merit dun sa organization who is actually claiming na is actually connected din daw po sa University of the Philippines?
So he's a professor of he's a professor in the mathematics department, but the firm that he's representing, Okta, is not a UP. It's not a UP entity. Just like I'm trying to be careful not to bring the whole College of Science. Even if I'm the dean, I'm not saying that this represents the College of Science, but I am using the numbers of the UP pandemic team, and if you want to check it out, I actually put in the links there so that you can also verify what I have been saying. Ganun lang naman din tayo sa pag-present ng mga data na to. We can have the analysis, but at the end of the day, the data has to be there. The procedures to get to those plots, I know how the UP pandemic team derived it, and we can do it as well. Can go through it step by step. But may, yun yung yun naman yung kailangan natin, and that's probably the call to DOH more than to Dr. David and the rest. It's for the DOH to open their data, put in all the relevant numbers there to complete their validation, so that everybody can go back to raw data to check what we can extract from it, so that we can be guided in policy.
Yes, po. Sige. So before we let you go, Professor Gani, on the side po of AGHAM, as advocates of science and technology for the people, what would you comment, especially with regards to the problems? Lalo na po yung laging sinasabi na ang focus lang is flattening the curve. Does it distract from the bigger problems natin? Lalo na dun sa usapin ng kalusugan at siyensya sa Pilipinas.
Well, what I said earlier was na it's not really just about the numbers of hours of T, doubling time, etc. Because these are just numbers of the cases. And at some point, you have to take into account, why are we looking for quote-unquote flattening the curve? This always has to deal with that dashed line there of health system capacity. That's a catch-all phrase for everything. That includes hospital capacity, bed capacity. That also includes human resources. That also includes actually not just health system capacity, but even the economic capacity of our people to sustain themselves in this pandemic. Kasi kung hindi mo iintindihin yung dashed lines na yun at doon naka-context yung flattening the curve mo, ang laging target mo lang is just to lower hours of T to less than 1. And it's misleading, quote unquote, because the time when we were having hours of T 0.64 in April, the number of cases were just in the hundreds. Ngayon, the number of cases already are in the tens of thousands. So that means you have tens of thousands individuals that are able to infect tens of thousands more. So even if you have 0.5 hours of T, you have 10,000 individuals, you have 5,000 new cases. So yun ang ibig sabihin ngayon sa mas malaking baseline number ng ganong hours of T. So pag nireduce kasi lang siya sa hours of T at hindi mo ikinonteksto, baka misleading sa mga policy makers. Of course, it's easy to talk with technical people, with doctors, epidemiologists, pero hindi naman epidemiologists ang nag-decide for the policies, unfortunately. Nor even if you have the recommendations of our doctors and epidemiologists, hindi rin naman necessarily nagka-translate sa actual policy that we can use. So yun naman yung yung from our side in AGHAM, it would look at it in a more comprehensive manner than just looking at the numbers, because the numbers are easy to generate once you have good data, so you really have to open the data. But once you have the good numbers, the policy question has to come in. How do you deal with this kind of numbers? What actions do you need to do? And up until now, medyo hindi natin naiintindihan. Hindi pare-pareho yung approach ng ating government with this, from top to the regions to the. So medyo mahirap pa rin sa i-deal, and it's already been like 5 months in this pandemic. 6.
And especially frightening din po, Doc, syempre yung nadadating sa mamamayan, no? Yung lumalabas na, all the things about the data, especially for a lot of people na hindi naman sobrang naiintindihan ng hours of T and the doubling time, no? And syempre, ano yung dating nito, no? For the most people, na ganito lagi ang language na ginagamit ng ating policymakers and analysts.
Mahirap talaga i-reduce into one number. Ang isang ko na lang siguro, idagdag pa, kailangan din natin talagang i-foresee ang effects ng, say, opening of classes in October 5. Although most of it will be online or remote, there will still be some activity related to that, and we have to factor that in as well. So yeah.
Opo.
Alright.
Sige, maraming salamat po for your time, Professor Gani, and we won't keep you from the other things that you have to do. So thank you very much po for your time. Tapos kung may additional questions na lang po tayo from the audience, I will just get your side na lang po. Maraming salamat po, Professor Gani Tapang, ng National Chairperson ng AGHAM. So yun po, no? So talagang nakikita natin, no? Bagamat meron tayong nakikita sa datos, no? Yung mga data, hindi pwede, no? Mag-rely lang tayo on certain parts of data that support something that we want to see. No? Yun po kasi yung nakakatakot na imbis na tingnan natin sa kabuuan yung datos na nangyayari, dahil nga po maraming problema tulad nung kabagalan ng resulta, no? Posible kasi nga nakikita lang natin ngayon yung effects of having an MECQ in early August, no? Syempre, may delay ang ating datos, no? Hanggang ngayon, meron pa rin tayong nababalitaan ng mga kaso mula nung Marso na ngayon lang nare-report, no? So meron pa ring aspeto nung delay or yung mga backlogs, no? Nasabi nga po ni Professor Gani, meron pa tayo nung ilang libong mga kaso na hindi pa rin natin alam, no? Kung confirmed na po ba sila or nakadagdag na po ba sila dun sa data na nilalabas natin sa pang-araw-araw ng Department of Health. So marami pa po, no? Kailangan tingnan yung data sa kabuuan at syempre ibang usapin. Kung ito nga ba yung nakikita natin sa mismong on the ground, no? Sa mismong mga ospital, sa mismong komunidad, no? At kasi yun nga po yung nakakatakot na may ibang nagiging kampante masyado doon sa paniniwala na nagpa-flatten na ang curve at maniniwala na wala na pala masyadong pasyente sa mga ospital. Pero ganito nga po ba ang tunay na kalagayan? Marami na po ba talagang gumagaling? Tulad ng nire-report kada linggo na sobrang daming gumagaling, no? It may send the wrong message sa maraming kababayan natin na wala na raw laman ang mga ospital. Pero syempre, ibang usapin yung datos, ibang usapin ang mismong nangyayari on the ground dahil nga sa mga delays and backlogs. Okay? So, ito ang aalamin natin sa ating susunod pang mga speaker. Ang ating susunod na magsasalita at mga kapanayam natin ay nagtapos, no, na medisina sa University of the Philippines College of Medicine at siya po ay nagpadalubhasa sa Internal Medicine at Pulmonology sa Philippine General Hospital. Siya po ay kasalukuyang intensivist at pulmonologist sa St. Luke's Medical Center, Bonifacio Global City at isa din pong medical volunteer sa Philippine General Hospital. So, inaanyahan po namin si Dr. Johnray Magallanes para po mas mapaunlakan tayo. Ano po ba talaga yung kalagayan na sa mga ospital? Magandang hapon po, Dr. Johnray.
Magandang hapon, Josh.
Sige po. So, sir, kamusta naman po in your experience, no, lalo na po na kinakaharap natin both the public side and the private sector. Kamusta naman po yung kalagayan ng mga patients natin?
Okay, so I'll parang magbigay lang ako ng overview on how I work. So
Yes.
in general, I go in parang every week for every 3 weeks na duty sa junior consultant sa PGH, no. So previously nagtawag ng volunteers for graduates of IM and Pulmo yung PGH kasi yung consultant pool and the resident and fellow pool not enough to make rounds every day and to supervise the fellows going on rounds every day for our COVID patients and also for the non-COVID patients. And then when I'm off for that in between na 2 weeks, I'll be on duty, no? Depende yung sa schedule namin. I'll go on duty every mga 5 to 6 24-hour shifts a month sa St. Luke's BGC. Okay. So ito nangyari, nag-start yung COVID sa St. Luke's, sa mga private institutions, una siyang naramdaman. March, April, nagkaroon ng unang surge. Medyo na-overwhelm yung system namin. At first, we were unprepared for the flux of patients. Okay? Nagkaroon ng problems sa ER level pa lang with regards to how we manage COVID suspected and non-COVID patients. Okay? And steadily, no, throughout the months, nag-allot ng several wards and beds as well as ICU for COVID patients. So from March, April na meron lang kaming nag-start yun ang COVID capacity ng ICU namin 12, tapos isang ward lang sa floors. After that, ngayon meron na kaming 23 bed capacity na ICU sa St. Luke's, and then we are servicing 3 floors. Pero nung surge nung I think nung around May, June, okay, dumami pa yung wards niyan na sinaservice namin. Alright? So right now, okay, I had the census with me. This is in direct communication with the chief of IM sa St. Luke's, no, si Dr. Gargar. Ang total bed capacity ng COVID floors namin is 88, 77 yung occupied. So we had 11 vacancies as of yesterday 9 p.m. Sa COVID ICUs, so we have a 23 bed capacity na ICU. Isa lang yung available doon. Alright? So that's for St. Luke's. Ang problem with most of our patients, kahit makikita natin na nag-flatten yung curve sa mga reports, usually yan may delay na magre-reflect sa hospitals. After the GCQ, for example, we felt na nag-lull or nagbaba yung census namin mga 2 to 3 weeks after pa. No? I think, ano naman yun, parang expected for the natural course of the disease. So, right now na nag-decrease o nag-stop na nag-quarantine tayo, no, mid of August. Okay, so itong September first 2 weeks dapat namin makikita yung decline. All right, so we see a decline in the admissions sa ER. Okay, so to give you an idea, sa St. Luke's to, so during the surge, ang waiting time sa ER namin mga 5-7 days. So yun yung average from the ER na magwe-wait ka para makapasok ka through the ICU or through a common COVID room. Okay, for a private hospital, that's long. That's really, really long. Right now, isang day na lang yung waiting time mo. So you get to be admitted 24 hours, within 24 hours, kapag dumating ka sa ER. So that's a lot of improvement. So that means konti yung nagfo-flux sa ER ngayon. However, katulad nung sinabi ko, we have 11 vacancies sa COVID floors na may 3 wards ngayon. So that's a lot. That's 77 over 88. And we have 22, okay, over 23 ICU beds. Okay. Ang isang nakikita kong problem kasi with COVID patients, especially the severe ones, no, the ones who get intubated, matagal yung course nila. Okay, they spend minimum 1 week, okay, sa ICU, on average 2 weeks. Pero some patients stay with us for even up to a month or even greater than a month. Okay, the longest that we've seen stayed with us for about 32, 33 days. Okay, so I can imagine, no, if matatapos tong lull period na effect nung MECQ, kung ganito kami ka puno ngayon and then magse-surge ulit, I think masihina yung capacity namin to absorb it. Okay, than how much we can absorb nung nag-GCQ, following the GCQ last July. All right, now PGH, we also seen a drop of ER visits, consultations starting first week of September. Okay, again expected. My last rotation in PGH was first week of September. Puno yung ICU. I was the ICU team captain during that time. Same. Wala kaming yung movement ng patients from ward, ER, and ICU very minimal. Okay? Sadly, unfortunately, nakakaroon lang ng patient movement, okay, na horizontal and vertical kapag may mga mortalities kami. So that's telling you something na we still have a great problem with that. Okay? And even sa PGH, the patients are staying the same, no? 2 weeks to up to a month sa ICU. So they take up a bed, okay, for a very long time. Okay? So I also asked my colleagues, okay, so I posted some questions on my Twitter account asking for my colleagues, no? And may mga particular na mga provinces ako na i-highlight ngayon, no? Some of my colleagues from Iloilo, Dr. Lasafin and Dr. Manwa from who's been practicing in Iligan and Marawi. No, both of these cities are seeing a surge of COVID cases right now. So in Iloilo, they said that uh, in the at the front lines, the curve isn't flattening. No, yung COVID cases sa kanila is rising. There are a flux of patients going at the ER, saturating the COVID wards of the designated COVID hospitals. Okay, nagdadagdag sila presently ng mga COVID beds, but even so, nasa-saturate siya. Right? So, nagiging problems nila, uh, OB admissions, OB normal admissions, neuro ICU admissions, so your stroke patients, and especially HD. And I think common to, Manila, Iloilo, Marawi, chronic kidney disease patients have a hard time going into dialysis centers that are accepting COVID patients. Sobrang konti nun. Okay? Even sa PGH, most of our patients na nagsisik ng hospitalization would be CKD patients na happens to be COVID positive. All right. Marawi and Iligan, not flattening. Okay, so Marawi, now they see 8 to 15 patients a day. Okay, previously daw mga 1 to 5 lang. All right. Usually doon 2 to 4, 2 to 4, 2 to 9 patients na a-admit tas natetest na positive, 1 to 2 goes to the ICU. Okay, even the numbers are small, you must also appreciate that isa lang yung tertiary hospital na COVID center sa Marawi. That's the Amay Pakpak. Ang problem nila ngayon, they only have 60 COVID kits no na testing. All right? So after pag naubos daw 'yon, so babalik sila dun sa dati nilang practice. And yung dati nilang practice is that they tend to admit patients and treat as COVID kung nagpapakita ng symptoms na parang COVID. So parang admit all kung parang COVID. Okay, so nagkakaroon ng problems. So madaling maisip na nagkakaroon ng problems with regards to discharge, management. Okay, there can be some errors in sending out patients and dapat naka-quarantine and all. Right? So right now, so what I can say is even if the numbers are decreasing, it is expected during this time. Okay? But even if the ER visits are decreasing, the number of inpatients hindi siya masyadong gumagalaw. Nagka-admit pa rin masyadong patients. Most of our hospitals are still saturated. So if magkakaroon ulit ng parang surge after mawala yung effect of the last MECQ sa Manila, no, it could be more dangerous. So I think yun lang for my experience as a frontliner. Josh?
Okay, sige. Thank you po, Doc Johnray. I just want to clarify with regards to, since you've seen both on the private tsaka po yung public side, no, it seems na talagang mas mahihirapan. Although both sides, of course, syempre may difficulty with the absorptive capacity, especially with surging of cases ngayon. No? Kasi di ba we saw that in March, na yung naunang mga mapuno are the private hospitals,
Yes.
primarily probably because mas may kaya, no, yung mga nakakapunta. But the reality is that now, na dati yung private hospitals lang napuno kasi sila lang yung COVID centers. And then when we decided na magkaroon ng public COVID centers, ngayon punong-puno na rin sila. So if ever there is a surge, it's technically mas malala siya kaysa nung nag-start yung ating ECQ, no, back in March and April. Pero would you think po na parang now, sabi niyo nga po, yung problems natin are with regards to the mobility of patients. I'm sure there are a lot of patients na dinadala pa natin kung saan-saan. I mean, nakita niyo na po, no? Before, have you had cases where these patients in the ICU of private hospitals get transferred to other hospitals po because of problems of cost as well and yung mga because ang prolonged talaga ng care nila. Do they get easily transferred out of the ICU towards the wards or doon sila sa hospitals that are nearer to where they come from?
During the surge, especially nung April, May, tapos yung June, May, June surge, ang na-experience namin, especially for PGH, nakakatanggap ka ng patients na galing na sa iba-ibang hospital, no? And then coming sa ER, walk-in, not transferred, okay? Supposedly, PGH would be admitting patients na direct transfer from other COVID hospitals, seeking more specialist care. Pero hindi nangyayari yun, okay, most of the time. So, dadating sila toxic, only gets to be intubated at the ER sa PGH, and then ma-ICU, pero mapipila siya. Okay, kasi puno. Okay? And then, mataas yung mortality rates namin sa ER for COVID during those times. Okay? And some, totoo yun, yung mga lumalabas yung test nila only after being a statistic. Okay? So yun yung nagiging problem. With regards naman sa St. Luke's, same in a sense na they had to jump from hospital to hospital. But I think ang problem kasi may choice ka if you have the money. Okay, you have the capability of transfers, you have your own car, you can call an ambulance. You can only imagine kung ano yung nararanasan ng ibang may COVID. Especially yung mga galing talaga sa mga poor areas ng community. Mind you, taga-Tondo kasi ako, most of our patients from PGH are coming from Tondo. Okay? And most of them, okay, nagpaiba-iba pa ng hospital. Taga-Tondo siya, pero pumunta ng QC, pumunta ng Pasig, bago nakarating ng PGH. So, if you don't have transport, for example, medyo mahirap for you makapasok sa hospital. And syempre, mag-i-increase ng risk mo for mortality. With regards sa gastos, okay, sa gastos naman, syempre pag private, you can spend millions. As I said earlier, you could stay for 2 weeks to up to a month. Okay, and your bills keeps on growing and growing. And these patients are intubated, they go on dialysis, continuous renal replacement, tons of transfusion sometimes, all right? And your COVID medications, the investigational drugs, are not cheap, okay? Sa PGH, some investigational drugs, okay, nabibigay siya for free, pero not all. Okay? May benefit din ng ma-enroll ka sa trial. So, I think yun yung parang edge niya a bit. Okay? I think yun, mostly.
And you mentioned kanina, sir, yung with regards to the patients na transfer, no? And then eventually darating sila sa emergency room ng toxic. Is there a possibility that some cases are actually just mild or moderate, tapos nagiging severe sila because of the fact that care is prolonged? Dahil hindi agad sila nakakapunta into seek urgent care, kaya sila nagiging mortality or further morbidity to the hospitals?
Yes. So, a common history would be pumunta sa ER mga 1 week ago. Okay? Sent home, awaiting a room. Okay? You're supposed to be in a room, pero you were asked to monitor yourself, monitor your temp. Okay? Some are being asked to buy a pulse oximeter just to monitor their oxygen. And then, comes back rushing to the ER na mas toxic, gets intubated, goes to the ICU. So, maraming ganong kwento. Halos ganon, lalo nung surge, lalo na from PGH. Okay? Sa PGH naman, ito yung mga tao na not really poor, pero mga middle class na nakapila sa ibang hospitals and yet hindi sila ma-accommodate. And then they have parang some hospitals kasi can turf, okay? PGH cannot. Parang gano'n, PGH cannot. So talagang i-absorb niya lang 'yun. So in effect, sometimes we catch them late, okay? They're towards the end of the disease. Wala pang proven medications talaga on whether can we give early, masasave ba natin sila. But you cannot erase that at the back of your mind na what if nag-intervene tayo mas earlier, baka hindi naging ganito.
Or nalaman natin na positive cases sila that
Yes.
were,
Yes. Nagka-problem kami yan nung there was a time na wala pang mga testing sites na accredited even for St. Luke's, no? Even for the MRL of PGH, we send them out. Okay? And the results will come back days later pa. Okay? Pero fortunately, I think dapat nag-work naman yung alam mo yun, yung pagde-decide who's to get to be admitted. However, syempre there was this notion then that asymptomatics were not able to carry the disease, di ba? Na we know right now is not entirely true.
Sir, would you say na umabot na tayo dun sa time na yung kinakatakutan ng maraming doctors? Yung parang nangyari sa Italy that some doctors had to make difficult decisions kasi parang nagiging decision na who gets to live or who gets to die in terms of who gets the better care, no? Lalo na kapag kulang yung kwarto, kulang yung capacity. Nagkaroon na ba ng opportunity or time na unfortunately ganun yung naging choices of many of our frontliners na ayaw sana natin mangyari?
Fortunately, wala naman. There were clutch calls. Lalong-lalo na yung huling call last August. Okay, yung nagkaroon na naman na napupuno na naman yung private hospitals, census ng PGH goes overboard from 190 na cut off to 100 to 20 nagdadagdagan ng beds. But there was never a time talaga na we are to decide who's to get the ventilator and not. Wala pa namang ganun. Okay? However, may mga decision ka na who gets to be admitted first sa ICU. So, yun. 'Di ba? And namamatay yung iba sa ICU. I don't have the numbers exactly, pero may mga anecdotes na ganun yung nangyayari. And I think madaling ma-imagine yun during the search. That's why there was a tough call from the doctors then, no? Na pulmonologist, IM, lahat halos actually ng doktor na na-overwhelm ng COVID during that time. Not because pagod, okay? Pero kasi hindi lang talaga kaya ng system. Okay? And it hurts a lot when kapag healthcare workers and doctors yung mga nagkakasakit and they can't get anywhere then. And they have a hard time being admitted themselves and their families. Yun.
So, yun nga po talagang even with the healthcare workers na paano pa kaya the other patients na
Yes.
wala talagang connections at all with their hospital. So last thing na sir before we end in this part of the segment, would you say that yung kaya nga no, nag-MECQ tayo and then ngayon medyo bumababa yung cases, would you really say na nagkaroon ba talaga ng time out or even a recalibration of the efforts? That's why yung merong alleged na flattening daw of the curve.
I won't say recalibration. Parang mga stopgap measures lang to mga GCQ, MECQ. What I can see is that since nandun na tayo sa thousands and tens of thousands of cases, na kahit mag-double yan, ng kahit a fraction of it, madaming magsisurge sa hospitals. I can see sa future na magkakaroon tayo ng regular going in and out of GCQs, MECQs, just to get by. Pero that's just to get by, no? Para lang hindi ma-overwhelm yung health system. Okay? Kung na-overwhelm ang Manila, what more ang Iloilo, what more ang Marawi? No? They can't handle as such. Kaya nga mas takot yung colleagues ko doon. So, Yes, bumababa and may nagpa-flatten yung curve, pero I'm doubtful that it's permanent. Pwedeng temporary lang siya. And because we all know that quarantine is not the ultimate solution to flatten the curve, still finding the sources, testing, identifying the people who are going to infect other people, treating them, and even the post-admission care. Okay? Uh, Still prevention. Okay? Pero unfortunately, medyo malayo na tayo from that. Sana.
All right, sige. Thank you very much, Dr. Johnray, for your sharing sa atin with
Yes.
regards to the clinical aspect, no? Yung ano nangyayari sa hospitals and a lot of our frontliners, what they're experiencing during this time and whether talaga nga bang flattening the curve on the ground, no? So thank you very much, Doc. And hopefully we can get more answers from you, no? Later with the questions ng ilan sa
Yes, and
ating audience.
sorry, Josh, and if I
Yeah, pa.
may add,
Yes.
may mga collaterals kasi tong COVID, no? Yung mga non-COVID patients natin na used to go to the hospitals, sila yung hindi natin alam yung excess mortality from that. Okay? Yung mga cancer patients, CKD patients, grabe yung problem with that. Marawi, Iloilo, St. Luke's, PGH, all nagkakaroon ng problems with CKD patients. Kahit nga PUI ka lang na CKD ka, mahihirapan kang mag-dialyze. So, yun yung isang problem. Access to these centers. Isa pa, yung mga gamot. Okay? Hindi siya like, finite lang siya. So, hindi siya unlimited supply. Nauubos siya from time to time. So, I think yung stockpiling ng meds dapat nandun lagi. And staff. Alright? So, there have been cases na nagkakaroon kami ng problems with HD nurses, no, na nag-quit both sa public, private HD centers. So I think yun yung isang statistic na hindi nare-reflect kapag pine-present yung mga flattening of the curve and stuff. The non-COVID cases na collateral ng COVID.
Yes, yung essential services nga ika nga that are supposed to be
Yes.
essential, but unfortunately because of what we are experiencing with the lockdowns as well as the yung limited capacity and yung pag-divert of resources towards the COVID-19 pandemic, there are a lot of problems in sa delivery ng dapat essential na services. And yun nga po yung nakakatakot, no? Especially sa lung cancer patients, dialysis patients who should be receiving the care that they should on a regular basis kasi alam naman natin na chronic diseases talaga sila. So yun nga po yung nakakatakot na kinakaharap. So siguro additional na lang din po, Dr. Johnray, are there any additional things you would like to discuss with regards to in both the public and the private aspect?
I think ginagawa naman na ito ngayon ng mga hospitals. And I think sharing of best practices within hospitals, within LGUs, should help one another. Okay? Yung kung ano yung nag-work for one, pwedeng mag-work sa iba. And I think that could help LGUs innovate kung ano yung pwede nilang gawin to augment their health system capacity. Kasi in the end, right now kasi unfortunately, medyo nakadepend tayo dun sa sa absorptive capacity ng health system capacity natin. Kasi nandiyan na talaga yung numbers, no? It's not going down anytime soon.
Alright. Sige. Sige. While we're waiting po for our third speaker, no, I think nagkaroon lang po ng konting technical difficulties yan. Siguro we'll just mention as well, no, yung reality pa rin po talaga that there is really that discrepancy pa rin nung kakayahan, like you mentioned nga po, with Amay Pakpak in Marawi. The reality is that even doon dun sa testing, no, even yung testing capacity of other areas are really not as good as Metro Manila. Metro Manila already has more than 40 testing centers and yet hindi pa rin siya enough, no? Hindi pa rin nakukuha ng patients natin yung results nila within 24 to 48 hours, no? As much as yung recommendation po dapat ng World Health Organization. And some patients still get their results after 2 weeks. So it's really a reality pa rin.
If I may add din dyan, kasi right now na parang, di ba, nag-open up yung mga business, mga ganyan, nakakasamang, okay, mga flights, no? Nakakasama ng mag-overload din ng system ngayon. Kakompete na namin yung mga, kunwari, overseas workers na aalis, seafarers na aalis, kunyari mga foreign nationals na nandito na aalis, who needs to get to be on an airplane, they need a swab, they can overwhelm testing centers. Okay? We had a problem as pulmonologists, for example, siguro, ito yung mga collateral ng COVID. When you test for PCP, okay, for example, for HIV patients, you will get a hard time sending for a PCP, PCR. Kasi most centers are testing for the COVID. They will not run your PCP because the COVID PCR business-wise is mas okay. Okay? So, na-surprise ako nung nalaman ko yun. So, there are, I think, yung mga hindi natin ina-expect na effect nung COVID. And I think mas marami pa yun.
Yeah, actually, pati yung sa HIV viral load, Doc, no, sa RITM,
Yes.
they actually shifted out, no,
Same.
kasi priority yung COVID.
Yes, same. And magwo-wonder ka, no, how are these people doing? Okay? How are these people doing? Are they dying? Are they getting more sick? Okay? Hindi siya nagre-reflect sa statistics natin.
Have you seen any patients, Doc, that have co-infections, either dialysis patients who had COVID-19 o kaya HIV and then COVID-19 na nag-worsen na yun?
Yes, marami ng CKD patients, HIV na, yes pala, meron na pala. So, yung mga ano pa yan, yung mga hindi pa diagnosed before. So, ang problem kasi with COVID, ang dami niyang kahawig na sakit. Okay, so, TB, okay, PCP, typical pneumonia, na bacterial, could all be COVID, no? So, even if PUI ka, no, makakasama ka kasi dun sa deluge ng patients mo. And this set of patients, hindi sila konti, madami sila. So, madaling maisip na nakaka-overwhelm siya ng system. Okay, and inaagawan nila yung mga non-COVID patients sa ICU. Kasi nga, they stay for very long time.
Okay, sige. Thank you very much, Dr. Johnray. We'll get back to you later kung may mga additional questions during our Q&A part before we end the program. Sige, thank you very much po dun sa sharing ninyo. Okay. Sige. So, yeah, ayun nga, sabi nga po ni Doc Johnray, talagang grabe nga po, no? Even yung situation natin doon sa ating mga hospitals, no? Na naririnig naman natin paulit-ulit na even as early as March, na napupuno ang mga hospital, tapos nawala ulit, tapos umulit na naman itong June. And then June and July, no, na talagang parang isabi nga natin sa Coalition for People's Right to Health na we went back to square one, no, na talagang bumalik ulit tayo despite na na-lift natin yung ating ECQ, bumalik tayo sa GCQ at nakita natin na parang umulit lang tayo. And that's really yung sinasabi nga ni Doc Johnray na may pagkukulang dun sa kakayahan ng ating healthcare system to adjust, and that a lot of that is really about yung baseline na kakayahan ng ating frontliners, yung ating healthcare system, and yung ating health infrastructure overall. And yung pinakatanyag no, na makita natin yung differences talaga ng iba't ibang bahagi ng Pilipinas. Yung bagamat ang Metro Manila nakikita natin kinakaya nung una, may nagkakaroon din ng mga panahon na hirap ang Metro Manila even if siya yung merong mahigit na 40 PCR laboratories, no? At siya rin yung may pinakamaraming COVID-19 referral centers, and yet hirap na hirap yung Metro Manila. Paano pa kaya yung ibang mga lugar sa ibang rehiyon ng ating bansa kung saan napaka-konti nung kanilang referral centers, napaka-konti ng testing facilities, at napakahirap para sa mga COVID-19 patients na malaman na sila ay positive at kailangan na silang ma-quarantine. No? So ano po ba yung kalagayan dito sa mga lugar na ito? Na-mention naman kanina ni Dr. Magallanes yung sa Marawi at sa Iloilo. Pero syempre yung ibang mga lugar na ang West Visayas halimbawa ay merong at least 8 testing facilities. Ang Marawi ay meron pong, ang buong BARM ay iisa pa lamang, no? Yun nga po sa Amay Pakpak Hospital. Pero maraming ibang mga rehiyon na ganun din po ang kalagayan, na 2, 3 ang testing center at isang region na iisa lang din po ang testing center ay ang Caraga. Ang buong Mindanao ay still pinakakonti ang testing facilities kumpara sa Luzon at Visayas, pero maraming bahagi ng Mindanao ay napaka-apektado. Halimbawa po dito yung sa Region 12 at sa Region 10 na napakataas ng mga kaso na halos kalibel ng Manila ang kanilang positivity rate, no? Yung bilang ng mga nagpo-positibo. Pero yung isang realidad ay napakakonti ng mga laboratory sa mga lugar na ito. Kaya gusto natin malaman din po ano na po ba yung kalagayan, lalo na sa mga rehiyon na katulad nito. Kaya swerte din po tayo ngayong araw na to at nakuha po nating makapanayam ang Provincial Health Officer ng Dinagat Island. Siya po ay graduated po ng Medisina ng UP College of Medicine at aking pong naging kaklase, si Dr. Jillian Francise Lee, ang kasalukuyang Provincial Health Officer ng Dinagat Islands, isa sa mga probinsya sa rehiyon ng Caraga, Region 13. So, magandang hapon po, Dr. Jillian.
Ako. Alright. Hi. Magandang hapon po sa lahat ng nakikinig ngayon. Ako po si Jillian Lee. Ako ang Provincial Health Officer ng Dinagat Islands. I think may slides ako. Sorry. Pwedeng yung slides ay i-show. Pero habang wala pa yung slides, ikukwento ko lang. Sa Dinagat Islands, isa kaming 4th class na province dito sa Mindanao, sa Caraga region. Madaming nagtatanong nung una akong na-deploy sa Dinagat Islands bilang as a part ng Doctors to the Barrios program kung nasaan siya. Isa siyang island province. Josh, I'm so sorry. May parang yung slides ay hindi hindi nag-share. Pwede ba natin siyang something? I think kailangan ninyong i-share yung screen ninyo at hindi lang ako yung nasa studio para makita si slideshow. Ayun, yay! Or baka delete, ayan, yon. Nag-work ba siya kung slideshow siya? Sige, go na lang. Kahit ganyan naman siya, okay lang naman sa akin kasi para lang meron tayong visual guide kung anong meron. So, ang province ng Dinagat Islands ay isang 4th class na island province sa Caraga region. So, meron kaming population ng 127,000. Tulad ng sinasabi ko minsan, ang population namin more or less isang barangay lang siya sa Metro Manila. Subdivided ang province namin sa 7 na municipalities, and tulad ng healthcare sa buong Pilipinas, ang healthcare sa Dinagat Islands ay devolved. So, ibig sabihin ng devolved na health system ay siya ay responsibility, siya ay nasa pamamahala ng ating municipal local governments at provincial local governments and ng provincial health offices. So sa nakikita na ever since na nag-institute ng devolution under the Local Government Code of 1991, medyo may inequities na nagaganap sa ating health system. Siyempre, mas may advantage ang mga provinces at ang mga provinces, cities at municipalities na mas malaki ang income, mas malaki ang internal revenue allotment, mas malaki ang budget na pwede nilang panggastusan para sa healthcare. So, isa sa mga provinces na medyo naiwanan after ng devolution ay ang Dinagat Islands. Sa buong province ngayon, meron lang kaming, sorry, pwedeng pa next slide at yung susunod pang slide. Sa buong province namin ngayon, 15 lang ang physicians sa buong probinsya. So, ang mga physicians na ito ay nasa aming 7 na municipalities, sa rural health units ng 7 na munisipyo, and sa aming 3 district hospital. Then again, ang mga district hospitals din namin ay hindi din sila totoong district hospitals kasi hindi sila nakakamit ng required na staff to patient ratio, hindi enough ang facilities nila, so hindi din sila accredited as district hospitals, accredited lang sila as infirmaries. Sa buong province of Dinagat Islands, since nag-start ang COVID-19 pandemic and since nag-start kami mag-institute ng quarantine measures, more than 9,600 people na ang pumasok sa aming probinsya. And yung over 9,000 na people na ito, ito yung mga taong pumasok sa province of Dinagat Islands na nag-undergo ng quarantine sa aming quarantine areas. Kasi since the onset ng, nawala din yung slides. Since nagsimula ang local transmission ng COVID-19 and since nag-implement ng ECQ ang Metro Manila, nag-implement din kami ng quarantine policies na lahat ng tao na papasok sa province ay required na mag-undergo ng quarantine, mostly as a preventive measure, as a containment measure for COVID-19. Since napaka-limited ng aming resources, napaka-limited ng resources ng aming health system, napaka-importante sa amin na hindi kami magkaroon ng local transmission ng COVID. Nag-start ang pag-increase ng influx of people nung nag-implement ng ECQ sa Metro Manila in March. And hanggang ngayon, hindi pa rin siya kumukonti. Sa ngayon ay over 900 na tao ang naka-quarantine, ay nag-enter ng aming province at naka-quarantine sa iba't ibang quarantine facilities sa buong province namin. Noong una, ito ay yung mga taong umuwi galing sa Metro Manila nung nawalan sila ng trabaho dahil sa ECQ. Ngayon, mostly sila ay mga beneficiaries ng Hatid Tulong Initiative ng national government. So ito yung mga locally stranded individuals, LSIs, and returning overseas Filipinos, ROFs, na pumapasok. So, nawala ba talaga yung slides? Oh, well, papel. Kasi may slide ako, sana, na may graph na nagpapakita na yung gradual pero hindi pa rin nawawala, hindi pa rin nag-abate na increase in persons entering the province. So sa influx ng tao na dumadating galing sa mga areas na may local transmission, meron diyang may COVID. Pero yung first namin na confirmed cases of COVID-19 ay naitala noong August 2020. So more or less 5 months kami nag-i-implement ng quarantine protocols before kami detect ng confirmed cases. Pero since March 2020 nga, nag-start na kami mag-implement ng mandatory quarantine sa lahat ng papasok. Itong mga persons under mandatory quarantine ay minamonitor everyday ng health professionals, and sa pagmamonitor sa kanila, 37 sa kanila ang nag-develop ng signs or symptoms of COVID-19 habang sila ay naka-quarantine. So 37 na yon, 20 negative for COVID-19 via RT-PCR, 8 yung naging confirmed cases. Thankfully, ang 5 sa kanila ay considered recovered na ngayon, and 9 yung pending ng results. Sorry, after pa niyan. Pero sa lahat ng individuals na pumasok, sa over 9,000 na individuals na pumasok since March 2020, 80 na sa kanila ang pwede mong parang naka-classify as presumptive recovered cases. Kasi as you know, yung antibody tests ay hindi naman sila reliable for detecting active infections, pero pwede silang gamitin to tell whether or not someone has had an infection of COVID-19 in the past. So sa lahat na over 9,000 namin na tao na na-quarantine, 80 sa kanila ang IgM negative, IgG positive. So ibig sabihin nito, sometime within the past 14 days to 3 months, sila ay nagkaroon ng COVID-19. And sa 80 na ito na tao, wala sa kanilang nagawan ng confirmatory testing. Wala sa kanilang ever na nag-develop ng symptoms ng COVID, or kung nag-develop man sila ng symptoms ng COVID, hindi sila na-test sa local government kung saan sila nanggaling, or sa probinsya kung saan sila nanggaling. And they arrived all the way here from wherever it was they came from, na possible silang carriers ng COVID. So medyo nakikita na ito pa lang ay maliit lang na sample ng tao. Konti lang ito sa mga over 2,000 na locally stranded individuals na umuwi sa iba't ibang probinsya galing sa Metro Manila via the Hatid Tulong Initiative. So konting-konti lang sila, pero sa mga umabot sa Dinagat Islands, ganito na kadami ang may history, indicative na may history sila ng COVID, pero never silang naging confirmed. So sa pa lang, sa mga umuwi pa lang sa kanilang probinsya sa Hatid Tulong Initiative, medyo nag-undertest na tayo. Sorry, pwedeng pa slide yung pang 8 na slide, pang 7 tsaka pang 8 na slide. Sa buong Pilipinas kasi, based sa latest data ng DOH, over 2 million ang tests na nagawa na since January 2020. Umabot na tayo sa wakas sa ating target na over 30,000 tests per day. Ito ay target natin noong April, at ngayon na September na, medyo nandiyan na tayo. So good job naman sa ating lahat. Pero hindi din evenly distributed ang testing na nagagawa. So sa 117 na accredited testing facilities ng DOH, iilan lang dito ang nasa Mindanao. 16 lang ang testing facilities sa Mindanao, and sa mga testing facilities sa Mindanao, sa over 2 million tests na ginawa ng Department of nagawa ng iba't ibang accredited facilities ng DOH, only 132,000 lang ng tests na ito ay ginawa sa Mindanao. So sa Mindanao, 0.6%, wala pa sa 1% ng population ang tawag natin dito. Wala pa sa 1% ng population ang na-test, and based sa positivity rate, ang positivity rate sa buong Mindanao ay nasa 7.5 pa rin. So mas mataas pa rin siya sa recommended ng WHO na sana na less than 3% para masabi na adequate yung testing na nagagawa. Karamihan ng testing sa Mindanao ay nade-direct sa SPMC, sa Southern Philippines Medical Center sa Davao City, which is also the end referral hospital for COVID sa Mindanao. So sa 132-ish thousand tests, 56,000-ish yung ginawa sa SPMC. Kasama na doon ang test sa buong Caraga region. Kasi sa Caraga region, wala kaming sariling testing facility. So 5 ang probinsya sa Caraga region, so Agusan del Norte, Agusan del Sur, Surigao del Norte, Surigao del Sur, and kami. Sa aming lahat, nire-refer namin ang samples, pinapadala namin ang samples namin ng suspect cases namin for COVID-19 sa SPMC. Nag-establish ang Department of Health ng isang testing facility in Butuan City sa Butuan Medical Center. Pero ang Butuan Medical Center ay mostly nagpa-prioritize siya ng patients from Butuan City, and pina-prioritize nila yung naka-admit din sa kanila. As of now, 347 lang na tests ang na-run ng Butuan Medical Center. And nagkakaroon din sila ng problem sa supply ng kanilang reagents at ng kanilang kagamitan na kailangan nila to process their test. So yung bulk pa rin ng testing ay pinapadala pa rin sa Davao, which for the record, is 12 hours away by land. 5 to 7 days ang normal na turnaround time ng aming results. So very limited din ang... Sorry, nawala ba ako? Yan, very limited din ang testing na nagagawa kasi nga since halos lahat ng provinces sa Mindanao, ang hindi nagpapadala sa Davao ay ang Cagayan de Oro, ay ang Zamboanga, hindi sila nagpapadala sa SPMC, ang Cotabato meron din silang sariling testing center, and yun sa yung Amay Pakpak din ay may sariling testing center, but everybody else, sa SPMC na pupunta ang kanilang sample. So very limited din yung testing. Ang nililimit ng SPMC sa 10 samples per batch per province or city. So sa amin, tapos 2 times a week na kami nakaschedule sa buong Caraga region. So isipin mo, ang isang region namin of 5 provinces, ang testing lang namin sa SPMC, kada Tuesday tsaka Thursday. At kada Tuesday tsaka Thursday na yon, 10 samples per province lang yung pwede mong ipadala. Okay lang naman yun sa amin kasi kami ay napakaliit na probinsya. Pero sa mga provinces tulad ng Surigao del Norte, ng Agusan del Norte, sa mga syudad tulad ng Butuan, na madami ang kanilang cases, madami ang kanilang suspect cases, hindi sufficient ito test yung population nila. So sa Caraga region, over 705 na ang confirmed cases namin. Pero ang tagal-tagal ng turnaround time, minsan by the time na bumalik na ang tulad ng nararamdaman sa Metro Manila, no, especially nung mga unang months, by the time na nakabalik yung results, either yung patient ay nakaikot-ikot na at nakalat na niya ang COVID or nag-expire na siya. Aside from the limitations on testing din kasi, aside from COVID, hindi lang din naman COVID ang concern natin sa health. Kasi aside from yung general concern, general burden sa health system ng pandemic, nagkakaroon pa ng additional na effect sa ating health system, not just because of COVID but because of the effects of COVID on our population. So ang pinaka-glaring din dito sa amin ay wala kaming access sa referral centers outside of the province because of the parang restrictions on travel. Tapos, natatakot din yung mga tao na mag-travel because of the risk na ma-expose din sila sa COVID-19. So, syempre, hindi naman nawawala ang ibang sakit. Hindi nawawala ang high blood, ang diabetes, ang TB dahil lang may COVID. Pero, meron kaming designated na hospital na nagsiserve as a COVID-19 referral hospital. Hindi siya pwedeng for all intents and purposes, limited na yung use niya kasi yung normal na patients na kung saan siya magki-cater, hindi na nakakapunta sa kanya. Napipilitan silang pumunta sa ibang hospital or hindi nila nakukuha yung adequate care yung care na kailangan nila. Pati sa labas ng province, ang referral centers, ang Caraga Regional Hospital sa Surigao City, doon kami kadalasan nagpapadala ng patient. Kasi siya lang naman ang secondary level public hospital na within like 6 hours ng province namin. Lahat ng iba ay mas malayo pa. Pero parang overwhelmed din sila. Lagi silang puno because of COVID and because kasi even before COVID, lagi din silang puno. So ngayon na panahon ng COVID, mas lalo silang napupuno. And parang since wala ding public transportation, parang exponentially nag-i-increase ang expenses sa emergency transportation on behalf of the patient or kung sinashoulder siya ng local government, sa local government din. Ang health human resources din namin ay medyo na-overwhelm na rin. 15 lang ang physicians sa buong probinsya. Hindi umaabot ng 100 ang nurses tawag natin dito sa aming 127,000 population, aside from sila ang nagmo-monitor ng mga pasyente na naka-contain and naka-quarantine sa aming quarantine facilities, ongoing pa rin ang kanilang regular functions, ang ibang health programs at ang ibang health initiatives na kinokonduct ng mga local government units. Pagdating sa supply chain management, ang mga gamot, ang mga personal protective equipment, even things na as routine as vaccines, nahihirapan na dumating dito because of the restrictions in movement, and kasi hindi din namin kayang, tawag natin dito, mag-spare ng person na magta-travel na madalas para kasi parang additional din na yun na risk sa kanya pag nagta-travel siya. Next, sorry. So yung health service delivery limited, ang normal na health programs, especially yung based sa school or nag-involve ng large groups of people, hindi na sila pwedeng i-conduct. So, ideally, gagawa ka ng adjustments to involve smaller groups. So, parang, for instance, sa immunization, hindi na pwedeng mag-conduct ng mass na immunization. Sa mass drug administration para sa tawag natin dito sa soil-transmitted helminthiasis, sa pagpurga, hindi na din siya pwedeng gawin in groups, which would be fine kung meron kayong resources para i-house to house ang mga tao. However, hindi naman lahat ng municipalities or lahat ng governments ay kayang mag-hire ng additional na personnel, or hindi lahat willing na mag-hire ng additional personnel, or parang dito sa Dinagat, konti lang din yung wala ka din namang masasagip na additional personnel na ma-hire. Ang national programs and guidelines din ay hindi din sila compatible kadalasan sa pag-handle ng COVID-19 and pag-adjust ng other health programs with regards to the pandemic. And of course, hindi nawawala ang impact ng pandemic sa social determinants of health natin, sa education, sa employment, sa livelihood, na nakaka-affect ng nutrition, na nakaka-affect ng stress levels ng pasyente, na nakaka-affect ng pangkabuhayan ng pasyente, at yan lahat ay magkakaroon ng impact sa kanilang kalusugan na magiging hindi na rin kayang i-manage if you have to handle that on top of the pandemic. So, yun lang naman. Kung meron pa kayong katanungan, pwede namin silang sagutin later. Thank you. Josh, hindi kita naririnig. I think ikaw ay nakamute.
Salamat din sa inyong pagpapaunlak in regions, no, na hindi talaga very uneven yung ating development talaga, na bagamat meron. Okay, sige. So yun nga, no, na talagang, no, hello, can you hear me? Rinig po ako?
Yep. Oo. Ngayon may sounds ka na. Kanina wala.
Okay, so yun nga talaga yung nakikita natin, na meron talagang problema dun sa pinagkaiba ng ating mga regions. Hello, Jill. So yun nga, no, na talagang yung iba. Jill, pwede bang explain niya ulit yung with regards dun sa yung naging situation, no, kung how kami hindi pa rin nagkakaroon ng testing laboratory ang Caraga, no? Kasi ang hirap nga talaga, no, talagang limited lang kayo to 10 in your province twice a week. no, para lang sa SPMC. Paano na kaya talaga yung ibang areas na magkakaroon ng outbreak, especially yung nangyayari ngayon, no? For example, yung paglagay ulit sa MECQ doon sa Jensan at Iligan. Paano kung mangyayari ulit yun in some areas? Paano kung magkakaroon ng outbreak? How can we handle that na titiisan natin yung dalawang yung dalawang testing centers in your province na hindi naman pala pinag-organize? Ano yung pwedeng gawin? Is there dapat ba na regional government ang initiative to have testing facilities in your region or in your province?
Honestly, talagang kailangan natin ng additional testing facilities kasi parang ngayon, and aside from additional testing facilities, kailangan din i-ensure na nakukuha nila yung logistics na kailangan nila, na nakukuha nila yung health human resources na kailangan nila. Kasi like dito sa Butuan Medical Center, private facility siya pero established siya with the assistance of the Department of Health, pero dahil nga nagkakahirapan sa supply chain management, mataas I think ang demand para sa reagents or nagkakaroon ng problem sa pagkuha ng supply, hindi din kahit na, so sana meron na, pero ngayon dahil kulang ang logistics nila, hindi pa rin sila maka-operate. So, kailangan mag-ensure ng Department of Health na meron talaga, ang target nila ay 1 per region lang, and meron silang targeted din na testing capacity per region na hindi din nila naaabot sa karamihan ng regions dito sa Mindanao. Ang SPMC, nakakaabot siya dun sa target na yun, kaso lang, yun ay, ang additional factor dun ay dun kasi pinapadala lahat ng ibang samples na lahat ng ibang probinsya. So, medyo ano din siya, hindi siya nagre-reflect sa, like, hindi siya indicative na sila ay totoong nakakamit ng parang ng minimum requirements natin for testing. So, ang targeted din na isa pa ay ang Caraga Regional Hospital dito sa Surigao City. Pero a few months na siya, tawag natin dito, level 3 out of 5. So, at nagsa-stand still siya doon sa part na yun. Ang problem mo din kasi ay, for instance, sa Caraga Region, wala ang mga personnel na meron sila ng enough wala na equipped na mag-conduct ng RT-PCR, because for the longest time wala namang molecular laboratory at walang molecular laboratory sa buong Caraga region. Ang mga taong may skills na ito, ang mga taong may background dito sa mga fields na ito ay nagsisialisan, nagtatrabaho sa ibang lugar, and ngayon hindi din ganun ka, parang yun nga, nagkakaroon ang DOH ng problem sa pag-recruit ng health human resources because of yung issues nila sa pagsahod, ang issues nila sa benefits. So mahirap din na ngayon sa panahon ng pangangailangan na hanapin mo yung mga tao na never naman silang nagkaroon ng opportunities na magtrabaho dito sa provinces before.
Yun yan, parang suddenly nag-expect tayo kumbaga no to have a functional health system in the middle of this pandemic, kung hindi naman pala talaga naayos ito bago pa yung COVID-19, no, na talaga naghahabol, no, short of saying na naghahabol talaga tayo para makuha natin no yung mga dapat magawa nitong panahon ng pandemic. I want to go back doon sa isang slide na pinakita mo kanina. Sorry, pakita lang natin yung isang slide. Yung with regards na yung disparity ng Mindanao talaga compared dun sa national, na yung although syempre pinagyayabang sa atin ng DOH that we've done almost 3 million tests. Yung reality is Mindanao has conducted even less than 100,000 na, 'di ba, for sa ng tao na posible merong
COVID-19. Sorry, ika-clarify ko lang yung slide na yan. Yan ay SPMC. So,
okay.
Yung sa buong Mindanao ay 132, sa lahat ng testing facilities sa Mindanao ay 132K na siya. So, wala pa siya sa 1% ng buong Pilipinas. And wala pa siya sa 10% ng sa buong Pilipinas. Sa 2 million ng buong Pilipinas, wala pang 200,000 ang na-conduct sa Mindanao. Ang bulk pa rin ng testing ay nangyayari sa Metro Manila. And tawag natin dito, sa Mindanao, ang pag pinagsama mo sa lahat ng testing facility, sorry, hindi ko na siya nalagay sa slides ko, 2,300-ish per day. Ang 7-day average nila. which
Right.
is so far basically sa 30,000 mo daily, less than 3,000 ang nasa Mindanao.
Mm. And grabe talaga no yung makikita natin na in some areas no talaga pumuputok nga talaga yung mga positivity rates. So based on this no sa daily positivity rate pa lang na although syempre may highs and may lows pero yung general trend parang hindi mo pa nakikita yung flattening. Ika nga ba?
Sobrang hindi pa. For instance, kung titingnan mo ang Butuan Medical Center na sila ay nagte-test lang sa Butuan, 31%.
Ito nga,
So,
yung
bukod sa
31.7%.
wala kang enough testing na nako-conduct, sa konti na testing na nako-conduct mo, yung based sa positivity rate, parang okay, it's not happening yet.
Yeah, and yung sabi nga 'di ba yung may dalawa kasing klase ng sobrang taas na positivity rate. And yung sabi nga ng World Health Organization, it's either indicative of these two things. Una, kung gaano karami yung iyong testing, no? If you're only testing a few people because konti yung iyong testing capacity, such as exemplified dito nga sa Caraga na dalawa nga lang yung laboratories mo and in one facility nga lang, and you're already testing at a 31.7% positivity rate. Siyempre, number one na siya in terms of all regions. No? Pero yung reality is that in Metro Manila, you also have a high positivity rate, which is an indication na hindi pa talaga
Hindi nako-control.
no? Hindi nako-control nga yung pagkalat ng sakit. No? So, two things na pwedeng mapakita. And ultimately, yung solution nga ay pataasin pa yung reality that is just one testing laboratory in all of Caraga. Sa pagkakaalam mo pa, Doc Jill, are there more efforts? I mean, are there nag-scramble ba na maggawa ng additional or mag-identify ng other hospitals for testing laboratories in the region?
Konti lang din kasi ang hospital sa region. So sa DOH, dalawa lang ang DOH retained hospital sa region. So Caraga Regional in Surigao City, Adela Cerati sa Tandag City in Surigao del Sur. Parehas sila na nag-apply na ma-accredit as COVID-19 testing facilities. And parehas sila na nag-apply noong like April and hanggang ngayon hindi pa rin sila accredited. Ang problem ngayon ay dahil sa lack of confirmatory testing, nagiging reliant ang ibang mga LGUs sa antibody testing kasi ang mindset din nila tulad ng mindset ng madaming ibang tao ay better na meron kang testing kahit na hindi siya accurate sa wala kang testing. Pero since siya yung nagiging basehan at mataas nga ang false negative rate niya, alam naman natin yan na hindi talaga siya accurate, nagiging dahilan pa siya ng pagkalat ng COVID sa mga munisipyo na talagang hindi talaga makaka-handle ng outbreak.
Yeah, nagkakaroon nga ba ng false sense of security dito sa ating health system or sa ating mga population?
Probably, kasi may mga provinces or municipalities na ang requirement nila for entry ay negative na rapid test. So feeling nila, pag okay, nag-require kami ng negative rapid test sa mga papasok, therefore tayo ay safe. Pero in practice, negative ang kanilang rapid test, hindi pa kasi sila nag-generate ng enough antibodies sa kanilang mga katawan para mag-positive sila, umikot-ikot sila, naglabas sila ng COVID. And before you know it, meron ka ng local transmission. So, ang mataas ng pag-increase na ng rates of COVID-19, hindi lang sa Butuan City. Ang Butuan City pa lang ang nagde-declare ng local transmission. Pero mataas pa din ang pag-increase ng cases sa Surigao del Norte and sa Surigao del Sur. And neither of which has tawag natin dito, testing facility.
And pataas talaga, no? Hindi pa siya, nowhere near yung usapin nga natin ng flattening o pababa na cases. Talagang dumadami pa lalo yung mga kaso natin in these areas. Kasi ngayon pa lamang tayo gumagawa ng testing. Which is ironic, how many months later, and especially how many months after na nagpadala ng maraming mga less tested na mga individuals through the Hatid Tulong program.
Yes. So ngayon, parang may kasi ang DILG din. So parang may memorandum circular din yung DILG na hindi na sila nagre-require na ang mga individuals na uuwi sa kanilang mga probinsya na fina-facilitate nila ay mag-present ng or ay matest ng negative. So, yung bulk pa rin ng tawag natin dito, burden sa testing sa kanila ay nagfa-fall para sa municipal and or provincial local government units. So, kung wala kang pang-test, sorry ka na lang.
Which is apparently a lot of the local government units sa atin, no, lalo na sa Mindanao. Sige. So, at this point, gusto ko lang ibalik din si Dr. Magallanes and si Dr. Lee para masagot natin, no, yung ating mga questions from our audience, no, before we end yung discussion natin para sa araw na ito. Sige. So welcome back, Dr. Magallanes and Dr. Lee. So, doon tayo dun sa mga discussion questions natin from our audience. Sige. So, sige, let's show yung unang question natin na pwedeng masagot. So, very contentious question. No? So, one thing kasi na tinitingnan, no, sa COVID-19 daw is infectiousness, no, or yung kung gaano siya kumakalat. Hindi ba daw dapat lethality or yung mortality of the epidemic yung mas mahalaga? Ano ba yung masasabi daw natin dun sa lumabas na PSA announcement last July 28, 2020 in which yung kinompile niya lahat ng registered deaths from January to June 2019, January to June 2020 actually, na similar lang daw. No, there's no major change or addition in the number of deaths from 2019 compared to 2020. So wala daw excess deaths that are ideally suspected or expected, such as what has been happening in other countries. So meron po ba kayo mako-comment with regards to the allegedly low mortality rate of the Philippines, kung bakit daw hindi tayo sinulala ng ibang bansa? So does that mean that there are problems dun sa ating handling, or gaano tayo kaswerte sa ating kalagayan?
Personally, I think mahirap i-isolate yung isang number ng
So
statistics.
any of our speakers?
Whether or not, sorry.
Oh, medyo okay. Na-disconnect lang ng slide si Dr. Magallanes. Sige, Doc Jillian, do you wanna add anything dun sa sinasabi initially? Or you wanna answer muna yung tanong na binibigay ni...
Ay, ayun na si Doc.
Ay, sorry.
Question?
Got dizzy. Na-dizzy lang. Can you hear me?
Ayan, mabalik na si Doc.
Can you hear me? Good ba? Alright.
Go ahead, Doc. Yes pa.
Yes, Josh, can you frame again the question? Sorry, naging choppy kasi towards the end.
Sige, Doc, naka-mute po yata kayo. But please go
Alright. Sige. So,
with your yung
I think
answer niyo po dun sa question ng audience.
So, I'll answer muna the question kung bakit kung bakit daw hindi tinitignan yung mortality rate on how we measure success, no? I think in isolation you cannot pick, no, mortality, prevalence, rates of infection,
Yes po, Doc.
whether or not you're
Go
successful
ahead po.
in dealing with in dealing with the success of your COVID management. I think you take it as a whole. Okay, you look at your curves, your R naught, mortality rates, the occupancy rates of your hospitals, how are your patients faring, no? Yung morbidity after the disease, we don't have any data
Sige.
on that.
Sorry, can we
Okay,
put
so
the
you
question back
can't
up? So
really,
basically lang po, no, yung hindi ba daw dapat mas nagmamatter in the data of a pandemic is yung lethality or yung kita ng mga tao, less na nga daw talaga yung namamatay kumpara sa ibang bansa.
yes, so I think yun. So wag mo ite-take isa-isa yung data.
Sige, Doc, sorry. Go ahead. Dun sa sinasabi kasi, no, the Philippine Statistics Authority actually released January to June 2020. No, it says that wala daw additional or excess deaths in that time. No? Pero it's medyo nakakagulat din kasi, no, na naglabas yung PSA so soon. Kasi usually our information about health data has a delay of around 2 years. No? So for example, this year lang natin nalaman yung health statistics about 2018. And then all of a sudden, naglabas yung PSA ng information regarding the deaths from January to June. So, may masasabi ba kayo, Doc? Or is it medyo suspicious na biglang naglabas tayo ng information that usually takes around 2 years? Tapos ngayon, mapapakita daw na medyo hindi daw dumagdag. No? Kasi yun kasi yung worry natin, Doc, diba? As we were talking about kanina. The deaths that are unrecorded as COVID-19, but overall contribute to the mortality that we see every year.
Okay, so with regards to that, I think yung unang-unang country na nag-publish ng reports on excess mortality rates in a year is Spain. Okay, so I think doon nagkaroon ng idea on kung paano mag-extrapolate ng data on how can we estimate the national mortality of COVID in our country. Pero that's our very, very rough estimation of the mortality rates. I think may number dyan ng DOH, no? I'm not sure. I don't have the data with me. Pero yung PSA data na like you said na naglalag ng 2 years, they should be very careful in interpreting that. Okay? So kailangan talagang real time yung data mo and wag masyadong mag-conclude ng statement kung ganun ka rough yung data mo. Okay? Lalong-lalo na if outdated siya. Personally, I don't know kung ano yung dates na included dun sa statistics nila on how did they identify the deaths, no? Hindi ko alam kung census lang ba ng hospital, whether PhilHealth death rates, mga ganyan. I really don't know. Pero let's be careful in interpreting excess mortality rates based on that. Even the Madrid team, okay, sinabi nila yon na caveat nila na masyado siyang rough estimation.
Mm-hmm. Doc Jill, meron ka bang ma-add on with regards to how long it usually takes yung information natin ng deaths in a province bago siya maiakyat to the national statistics or overall information ng ating bansa? Na usually nga may delay of around 2 years.
Alright, so hindi din ako familiar sa kung gaano, pero right now, kakabalik lang din sa amin ng data namin for like 2017. So, medyo matagal-tagal nga sila mag-process ng data. And yung validation din ay medyo may backlog. So, kung ang validation ng confirmed cases ay meron silang matagal na backlog, ang validation din ng mga causes of death ay meron din silang matagal na backlog. And lahat kasi yun ay paper-based pa rin na ginagawa. So, you have an investigation form. It's on paper. You send it to your regional office. Your regional office encodes it. They send it to the national government. So isa siyang medyo matagal na proseso na kung ano yung updated nilang data ay hindi necessarily updated sa totoong buhay. Ang second din naman kasi ay hindi lahat na kahit na sabihin natin na konti yung deaths na directly attributable to COVID-19, mahirap sabihin, parang mahirap yun na conclusion na i-reach kasi kulang nga yung testing na ginagawa mo. Madami namang namamatay ng COVID-19 na hindi lang sila na-detect na may COVID-19 sila. And aside from yung directly attributable sa COVID-19, well, okay, parang aside from that na aside sa kung highly infectious siya, kahit na konti lang yung mababa lang yung mortality rate, if it infects enough people, that's like a lot of people. And meron ka ding deaths na hindi sila directly attributable sa COVID-19, but pumapangit yun nga, yung madalas na nangyayari, yung conditions ng mga tao, hindi sila na hindi COVID-19 related, ang mga stroke patients namin, ang mga cardiac patients namin na hindi sila nakaka-access ng hospital care kasi ang ER sa Caraga Regional ay puros COVID-19. Hindi din, fair na sabihin na dahil mababa lang ang mortality rate ng COVID-19, therefore kebs lang tayo sa pandemic.
Mhm. Is there anything na mako-comment nyo po kung bakit possibly mas mababa yung mortality rates natin than countries like Brazil, India, and the United States? Kasi yun po yung nagpapadagdag doon sa feeling ng mga tao that things aren't as bad, no? That things are flattening or things are parang mas maganda yung itsura ng COVID-19 sa Pilipinas.
For me, I think question ulit dyan yung testing. No? How many deaths talaga yung natetest mo for COVID? Okay? And mind you, hindi lang ang presentation ng COVID, dyspnea, difficulty of breathing. Some of our patients come in for stroke, heart attack, no, lalo na sa young. So, ito yung mga taong pwedeng ma-miss mo na COVID pala without proper testing and all. And like I said before, ito yung mga tao na dadating na sa ER, coded, okay, stays in the ER less than 24 hours, walang benefit ng isang ng testing. Okay? So, ito yung mga pwedeng nami-miss and ito yung pwedeng makakapag-explain na medyo konti yung mortality rates natin, seemingly.
Yes, sir. Pero of course, the cases are still climbing, di ba? Yan naman po talaga yung
Yes,
nakakatakot.
yes. Like I said before, hindi mo siya pwedeng tingnan lang as mortality rate. Okay, kailangan lahat. In general, parang kung paano mo iti-take siya with regards kung ano talaga yung effect niya, yung prevalence rate mo and your mortality rate mo, yung effect niya dun sa absorptive capacity nung health system mo. Okay? Kung konti lang yung mortality rate mo as compared sa iba, pero grabe naman grabe naman din kababa yung absorptive capacity ng health systems mo, then you could run into trouble then. And I think that's what's happening with us. So, hindi dapat complacent na porket mababa yung mortality rate natin as compared to US, 'di ba? I mean, not to degrade us, pero comparing our health system to a first world country, medyo masyadong malayong-malayo 'yun.
Yes. Sige po. Si Jill, would you like to add anything to that? Okay, sige. Kung wala, we can... Okay, sige.
Hindi na, ako na.
Okay, sige. We move on to our next question. Sige, from the audience. All right. So, what is the mortality rate daw po of our frontliners? So, ilang doctors, nurses, health aides, and other health workers na ang namatay from COVID-19. No? So, alarming daw po kasi that the information that hospitals are more dedicated to a growing number of COVID-19 patients. So, sige Doc, would you have any idea? Although yung, sige pa.
Okay, Ako muna, I think meron akong data niyan for PGH. Okay, this is for PGH healthcare workers. Pero itong data na to is as of August pa. Okay, so wala ako nung latest. So this is specifically for nurses, doctors, residents, fellows rotating in the COVID wards. Okay? So in the COVID services lang. Ang COVID rates is less than 1%, 0.4%. Okay? That's low. Actually, nagulat din yung HICU, yung Hospital Infectious Control Unit ng PGH with such low numbers. Okay? And I think it has something to do with the provision of PPEs. Okay? Sa PGH, medyo maganda yung provision ng PPEs. Okay? Marami talagang PPEs na dedicated stocks na bibigyan yung mga healthcare workers. Now, I don't know of any data ng COVID sa healthcare workers national. Okay? Pero I would suspect that it would be higher in patients, in places who don't have easy access to PPEs for healthcare workers. Proper PPEs.
Yun pa rin po talaga, Doc, no? Kasi the reality is that, we have over 40 healthcare workers who have died already, no? Overall, including doctors, nurses, pero yung the stark reality is that meron pa rin, it's still a big part, no? Yung initially when we started COVID-19 in March, sobrang laking percent, umabot ng almost 20% of the COVID-19 cases yung healthcare workers. So definitely meron talagang part na may learning curve kahit papaano
Yes.
the health system was able to adapt. But the reality is that, in the past few months, nagkaroon ulit nung ilang healthcare workers who were getting infected again. So I think it's also a reflection of the fact that these health workers are also still coming from the communities, and also the fact that the health system is getting overloaded during these times.
Yes, I can see that as a problem, lalong-lalo na yung mga parang bagong hotspots ng COVID ngayon sa provinces, 'di ba? Kung doon magsa-start yun, usually kasi ang NIDOS nung COVID cases mo will really start in healthcare workers and their families kasi sila yung pinaka-at risk. So you would really expect high healthcare worker na infectivity during the start, no, nung mga local COVID hotspots mo. So if they weren't able to control it, okay, dun magkakaroon ng problem. So I think with that notion, provision of PPEs for healthcare workers kailangan strict. Okay? Not only the PPE, syempre yung ano mo rin, yung facilities mo rin, kailangan ready for it. And it's easier said than done. Okay, mga negative pressure rooms, mga donning doffing of areas, no? Hindi lahat ng hospitals natin capable of having those.
Sige, si Doc Jill, before we ask a follow-up with regards to the question earlier.
Okay, sorry, wala din akong data sa national kung ilan ang parang namatay. Pero yun nga, more than 40 frontliners since we started in February. And totoo ang sinasabi ni Dr. Magallanes ng kakulangan ng resources sa ground. Sa lahat ng binanggit ninyo na parang engineering na interventions na kailangan sa ating mga district hospitals at sa ating mga referral hospitals, parang wala yata kaming ganun. Ang PPE din kasi, medyo restricted ang supply. For instance, ang pinurchase namin nung March ay ngayon lang sila dumating. And for the first few months talaga, reliant kami sa donations galing sa private sector. Halos wala ding nanggaling sa national government or galing sa ibang agencies.
Okay. So yung with regards to that, no, parang with the testing as well, no, no mga healthcare workers. I just want to add lang dun sa tanong na yun. Yung kasi nakita natin a lot of areas, of course, the testing of healthcare workers meron siyang priority given yung prioritization ng DOH, no, that may special mention for healthcare workers, and they're tinatabi yung 30% in all testing facilities for healthcare workers. But of course, the question is that are healthcare workers still routinely being tested? Or meron na ding aspect kasi, do we still do active surveillance of cases of healthcare workers who regularly rotate, no, in the healthcare wards with COVID-19 patients? Kasi ang concern din is, do we wait for them to have symptoms or dapat ba binabantayan natin or inaagapan natin, and which is what we mean with surveillance?
Debate yan actually, no, given yung current situation mo, na given na konti yung testing centers, konti yung resources, seemingly routine testing ba yung dapat mong gagawin sa healthcare workers or not? Now, if you have information to back up such claims, okay, such claims, kung gusto mong magtipid, na dapat, I think hindi, targeted yung gagawin mo talaga. So, you screen for patients, yung mga symptoms, ganyan, tapos sila yung i-test mo. That would be parang, in a sense, parang may cost benefit na 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 advantage sana. Ideally, talagang i-routine testing mo dapat yung mga healthcare workers. Also for their sanity. Okay? I think the clamor for routine testing, kahit may 0.04, 0.4 ka na infectivity sa na COVID rates for healthcare workers, that clamor stems from yung stress and yung anxiety mo, okay, na nagtatrabaho ka sa isang COVID environment, and you are possible na magbigay ng COVID sa mga kasama mo sa bahay. Because these healthcare workers are also family members. Some go to their families. Yun yung medyo tricky na part ng pag-decision. So ideally, sana merong mandatory na testing, and sana it's free for all. And mind you, it's not free for all, especially for nurses. The nurses which have very meager salary, okay, sila pa yung kailangan magbayad for their tests. Yun yung parang off ako doon.
Mm-hmm. And yun nga yung parang insult talaga dun sa integrity of our healthcare system kung yung mga healthcare workers ay hindi din natin natetest.
Yes, actually they categorize you kung parang depende sa symptom mo kung magbabayad ka or hindi. Parang ganun. I think unfair.
Mm-hmm. Doc Jillian, ganun din ba sa inyo sa community? Are there also additional lalo na sa community, no, yung meron talagang prioritization for the healthcare workers in terms of testing?
Ay, okay. Nangyayari kasi sa amin, thankfully, yung sa namin, 20 slots per week, nagagawa din namin na i-test lahat ng healthcare workers na nagde-develop ng symptoms. Kasi yung risk din sa healthcare workers, aside sa sila ay mahawa, tapos pwede din nilang hawaan ang mga pamilyang inuuwian nila, pwede rin nilang hawaan yung patients nila. So, meron, I think most hospitals do this na, pero para lang sa mga hindi familiar, kung meron man, na may duty system na ikaw ay naka-assign sa COVID-ish area, COVID ward, ikaw ang tagabantay ng mga COVID for 2 weeks, tapos 2 weeks off. And kami, sa 2 weeks off nila, meron kaming designated din na facility for them kung saan sila magka-quarantine. And kung meron sa kanilang mag-develop ng symptoms of COVID-19, either within the 2-week, parang the 2-week duty period or sa 2-week na isolation quarantine period, sila ay tinetest namin. Pero hindi lahat ng areas ay may ganyan na parang capability, especially parang tawag natin dito, especially sa Metro Manila, I think na expected talaga na sila yung nag-shell out para sa mga testing nila. Sa mga kakilala ko na nagwo-work sa hospitals, kung meron sa kanila or sa family members nila na mag-develop ng symptoms of COVID-19, they have to shell out din. So, kung wala silang pang shell out, hindi na lang nila nalalaman kung ano yung status nila.
Mhm. Yeah, in connection to that, yung last question natin, sorry, one of our last questions, medyo overtime na kasi tayo. From Dr. Morphine White, a YouTube comment. No? So how about healthcare workers daw from non-COVID wards? No? Kasi healthcare workers from COVID wards do have the higher levels of PPE and are able to minimize transmission. However, in non-COVID wards, aside from lower levels of PPE, may false negative diagnosed patients and other possible means of transmission are still present, such as fomites, contacts with relatives, contacts among COVID and non-COVID assigned healthcare workers. Any comments daw po? No? So again, yung importance ng surveillance among healthcare workers.
Yes. So, yan yung important for both of my hospitals na nag-work ako. Nagkaroon ng outbreak sa non-COVID wards. Okay? Meron ding instances na patient presented na kakaiba. Okay? Hindi ko na sasabihin details. Basta kakaiba yung presentation, not the usual cough and dyspnea. Eventually tested positive. And eventually, yung buong, hindi naman buo, pero most of the staff of that unit, no, na-infect. Okay? Ang problem mo sa mga ganito, bukod dun sa nagiging positive and risk na mahawa yung healthcare workers, kapag nawalan ka and kapag na-quarantine yung a good number of your healthcare workers, magsha-shutdown yung unit. Okay? Pag nag-shutdown yung unit, mababawasan din yung absorptive capacity mo on getting more patients to be admitted. Naging problem natin to nung early part, no? And during the surge. Okay? People are coming in, lalong-lalo na sa non-COVID areas, no? Tas doon nagkakaroon ng outbreak. Your nurses, no? Some doctors naka-quarantine. Okay? And marami yon. Okay? And finite din ng number ng nurses natin. So, yes, a risk talaga yon na if you have no testing for non-COVID workers, na magkakaroon din sila ng COVID. Mhm. Hindi rin sila covered kung gusto mo magpa-test. Okay? Actually, pag non-COVID ka, parang mas mababa yung priority mo. Okay? Ang reason na kasi ngayon ay dahil may community transmission na daw. So, hindi mo alam kung nakuha mo sa labas or nakuha mo during sa work mo. Okay? Much like yung reasoning sa states ngayon. Na they will not cover for you kasi there's community transmission. You might got that infection outside, so we won't cover for you. So, I think unfair. Yun lang. So, again, aside from that, na medyo unfair siya, may actually ang napag-uusapan nga namin to, no, within our circle, parang mas protected pa, no? Kung titingnan mo yung rates mo ng COVID infectivity sa COVID areas, parang mas mababa talaga siya kaysa dun sa non-COVID. Kasi itong COVID areas na to, they go on schedule, na on-off weeks, mas mababa yung threshold mo na i-relieve mo yung patients mo na may konting symptoms, naka-PPE lahat. So, mas na-prevent mo. So, for those, I think for those na nagiging new hotspots for COVID, ito yung isa nilang kailangan tingnan. Provision of PPEs na adequate din for the non-COVID areas, no? I think may levels kasi ng PPEs, no? So, dapat may provision din dyan for them. And meron din provision for testing these people.
Especially, sir, kapag mag-resume na daw yung mga clerks and interns in our medical schools.
Actually, hindi ko alam kung paano yun mangyayari. Kung ako yung intern, takot na takot siguro ako.
Alright, sige. So, one last question lang po. I think masasagot po both you and Doc Jillian. Hindi, ito rin po yun. So, what yung thoughts on the resumptions of face-to-face duties at the state of the pandemic. If yun yan kasi 'di ba of some areas, for example in Cebu, no, yung when Cebu started to improve, no, allegedly nagpa-flatten na rin yung curve sa Cebu, some medical schools decided maybe it's time for medical school to continue, especially for the higher years na mag-rotate in the hospitals. But of course, it brings up a bigger question of accountability and testing. So, kaya Doc, may add ba kayo to the discussion on this question?
Kung i-resume yung face-to-face, tricky yan. For me personally, hindi ako papasok, di ba? Parang I won't risk, okay, all of the years na nag-aral ako for that. Tas ako yung isa sa mga frontline. But looking ahead, okay, sa current situation natin na parang wala pang end to in sight, okay, and parang kailangan natin ng tao sa future. Unfortunately, 'di ba? I mean, kailangan natin ng magmaman talaga extra workforce for this. Yung mga current doctors din natin, hindi natin sila pwedeng patagaling unemployed. So, how do we go about that? Mahirap na risk-benefit na analysis on whether to let them have face-to-face. Pero sana for me, i-limit and i-ensure na yung places on which these students will have interaction with patients limited lang. I can see them doing OPDs. I can see them doing that. I can see them doing ward work. Okay? Pwede pa in assisting surgeries na medyo strict and heavily scrutinize yung patients na for surgery. Pwede silang mag-assist. Pero yung routine ward work, OPD, I don't think so.
Mm-hmm. Especially since marami pang doctors pa nag-OPD.
Yes. And yun pa. So personally, yung mga consultants, maraming hindi nag-OPD. So why let the students, mag-OPD sila, di ba? For us, parang unfair.
Mm-hmm. Sige, Doc. So, yeah, medyo nag-overtime na rin lang tayo. But siguro as a closing part, and to get your thoughts na lang din po, no? So, I just want to add, no? So, kami at the Coalition for People's Right to Health, so ako as a co-convenor, I was also a petitioner in a Supreme Court petition, no, for the writ of mandamus for free and mass testing. So in line dun sa sinasabi niyo, Doc Johnray kanina, that testing must actually be free and mass for more people, especially those who need it, like suspect cases, close contacts, and the healthcare workers with regular exposure. This is something that we try to do, no? Since hindi pa nangyayari sa Department of Health level, yung our policies are not always working like this. So one of the recourses that we took was to bring it to the highest court, no, or the Supreme Court, as part of a constitutional right, no, of everyone to be for health. And one of those is that during a pandemic, is we really should find out yung COVID-19 status of these patients and those who are highly, most likely affected by it through their contact. So yung ginagawa nga po natin is to really hope for this, no? And it's been more than 70 days since we initially filed it in July 3, and kaninang umaga ay nag-file kami ulit, no, sa Supreme Court as an additional motion, and hopefully seeking an answer, no, na pumunta man sa oral arguments, or yung call pa rin natin is for our government to really realize the need for free and mass testing as part of our right to health. So yun nga po yung ginagawa natin ngayon as part of our advocacies, no? And something that hopefully more people in the healthcare sector can actually appreciate, kasi gusto naman nating malaman agad ng mga patients natin if they are positive, because of course it has a lot of implications sa ating healthcare system, lalo na sa ating healthcare workers who may be testing positive and worsening the situation. So with that, Doc, any last words or last comments before we end our discussion on whether we have flattened the curve at this point?
Okay, so I think whether we're flattening or not, kailangan hindi tayo complacent. Okay, parang hindi tayo panatag. We're still on guard. Okay, so wash your hands, don't touch your face, wear your proper PPEs. Okay, always advise your parents, the elderly to stay at home. Yun pa rin. And hopefully, hanggat wala tayong cure for the disease, it will stay this way. Okay? We will para siyang chronic disease, kumbaga. Parang nandiyan siya lagi, pero we should contain it, we should control it. Okay? And the way we should control it, kailangan yung guard natin hindi mag-let down. Okay? So lahat ng yung tenets mo of preventing the disease transmission, testing, quarantining, treating, and stuff, and monitoring, kailangan in place lahat. Walang mabibreak sa link. Kasi isa lang dun yung parang mabreak mo, okay, domino effect mo. Okay, and baka dumating yung time na baka maging Brazil nga tayo, di ba? So, we will be turning into mass graves na. So, wag naman sana. So, and aside from that, so, I think dapat wag ibigay yung blame sa mga individuals din. Okay, so I think yung call for the government to take charge nandun pa rin lagi dapat. Okay, kasi walang ibang aasahan talaga yung mga Pilipino. I think that's it for me, Josh.
Sige, thank you very much, Dr. Johnray Magallanes, for sharing your time sa amin. Alam kong thank you din dun sa inyong service, ginagawa niyo pong pagtulong sa maraming pasyenteng may COVID-19. Okay, so I think medyo busy pa rin yata si Professor Giovanni Tapang as well as si Doc Jillian na may emergency call lang for now, no? But I think na sum up naman nila yung ating situation that although yung data lumalabas nga sa mga datos na meron nga tayong pagbabagal dun sa mga kaso, hindi medyo masyado pang maaga para masabi nating nagfa-flatten na yung curve kasi marami pa tayong kailangan tignan. Isang bagay nga yung posible na baka epekto lang ito ng MECQ. Siyempre, pwede tayong magbunyi sa ngayon, pero pagkatapos ng ilang araw, ilang linggo, biglang tataas ulit. So, yun po yung mga posibilidad. No? Masyado pang maaga para masabi yun. Sabi nga ng World Health Organization, kailangan ng at least 14 days na deceleration ng RT para masabi natin na posibleng meron nga talagang pag-improve ng ating sitwasyon. Pero again, marami pang pwedeng mangyari. Yung totoo pa rin talaga ang kalagayan sa ating mga ospital na kulang ang ating healthcare workers dahil sila rin mismo ang naapektuhan ng sakit. And of course, yung ating healthcare system na kapos pa rin dun sa kakayahan. Bagamat dumadami yung ating testing facilities and testing centers, where are they being put up? May mga naiiwan pa rin, may mga nahuhuli pa rin. At yung mga lugar kung saan sila nahuhuli, tulad nga sa Dinagat, sa Caraga, at sa buong Mindanao, na maraming mga kulang pa rin sa testing facilities. Now, less than 10% ng buong Pilipinas ang napupunta na testing center sa Mindanao, dun sa testing positive. So, bagamat nahuli silang magkaroon, yung realidad pa rin ay maraming posibleng kaso doon ngayon na. No? Something na nakikita natin sa Marawi, sa Iligan, sa General Santos, and mukhang ngayon, so kahit sa Butuan, na may positivity rate na 31.7%. No? So tuloy nga po talaga, all the more na kailangan nga po natin ng free and mass testing dahil nga ayaw natin na hindi lang natetest yung mga tao dahil hindi sila prioritize, dahil hindi sila makabayad. No? Alam natin dapat na sila ay matest hindi lang dahil dito sa hindi lang dahil sa guidelines ng COVID-19, kundi bilang karapatan nila sa kalusugan. At kaya nga po, ginawa nga po ng Coalition for People's Right to Health ang mag-file nitong petition for mandamus to command yung tunay na may responsibilidad sa kalusugan ng mamamayan, ang Department of Health at ang ating gobyerno na talagang merong responsibilidad sa kalusugan ng ating mamamayan. So maraming salamat po dun sa mga nakinig sa atin, dun sa mga nagtanong, at sana po ay naliwanagan po kayo kung ano nga po ba talaga yung kalagayan, no? Na hindi nga pa nagpa-flatten ang curve at kailangan tuloy pa rin yung ating pagmamatsyag, no? Na mas bantayan yung mga kaso natin, tuloy pa rin nga yung ating mga pag-iiwas sa sakit, no? Yung preventive measures. Pero syempre kailangan lalo pang lumakas yung ating testing, yung tracing, quarantine, isolation, at yung paglabas ng tamang datos para malaman talaga natin ang tunay na kalagayan. Kailangan talaga pataasin at i-raise the bar ng ating sistemang pangkalusugan dahil hindi lang pwedeng stagnant lang po, no, habang kukurba yung kalusugan yung kaso ng ating mga kaso ng COVID-19 pababa, pero hindi naman umaangat yung kakayahan ng ating sistemang pangkalusugan. So maraming salamat po sa ating mga speakers nitong araw na to, si Professor Giovanni Tapang, si Dr. Jillian Lee at si Dr. Johnray Magallanes sa mga nabahagi nila tungkol sa realidad, no, na hindi pa talaga tunay na nagpa-flatten ang ating curve, na kailangan pa rin natin maging mapagpatsyag at magsuri, no, ng maayos ng ating datos at iwasan pa rin yung sakit na COVID-19 habang sinasagot yung ating mga responsibilidad sa ating kalusugan. So sana po ay samahan niyo po muli kami sa susunod na linggo na tignan naman natin maliban pa dun sa usapin ng flattening the curve kung talaga nga bang nagre-raise na ng bar lalo na po sa darating na 2021, no, dun sa lumabas na budget o yung pinanukala na budget ng ating gobyerno, kung talaga nga bang tataas na ang kakayahan ng kalusugan at yung kakayahan ng ating sistemang pangkalusugan para malutas itong problema ng COVID-19 at napakarami pang ibang sakit sa panahong ito. So sa susunod naman po na linggo, no, will we raise the bar? Ang ating tanong sa susunod na Huwebes, ganitong oras din po, alas 3 hanggang alas 5. Maraming salamat po sa lahat na nakinig sa Coalition for People's Right to Health na webinar, Have We Flattened the Curve? Muli, ako po si Dr. Joshua San Pedro, ang co-convenor ng Coalition for People's Right to Health. Maraming salamat po at magpakalusog po tayong lahat. At panawagan po natin ang patuloy na pangangailangan sa ating kalusugan na paglingkuran ang ating karapatan sa kalusugan ng ating pamahalaan. Maraming salamat po sa ating lahat.